you guys for joining today. This is the Entac Medical Investor Update event. As people come in, what we're going to do is have a technical presentation as well as investor updates, as well as testimonials from existing investors. Looking forward to having everyone in the room here today. Before we kick off, we just want to let you know we have a chat box open if you'd like to put anything in there as well. With that, let me go ahead and pass it over to Buddy Lyons to kick off with an initial update on the investment and how that's going. With that, Buddy, please step up.
Hi, I'm Buddy Lyons. I am the CEO of Entac Medical, and with me today is Dr. John Cromwell, who is he is a clinical professor of surgery at the University of Iowa. He's the Associate Chief Medical Officer for Surgical Quality and Safety, and he is the inventor of the technology and going to present how AI using in precision medicine for transforming post-op care. Before we get into John's presentation, though, I wanted to sort of make an announcement here that we had been raising a convertible note of $1.5 million. We were very pleased to announce that Clinical Technology, Inc. Came in and put a very nice slug of money in to polish off that note. The significance of that is that Clinical Technology, or CTI, is basically the sales arm of Entac Medical. They are a contract sales force that cover 20 Midwestern states and hundreds of hospitals in that area. They've been in business for over 40 years and have launched scores of products in surgery and in critical care. And I think that's a terrific testimony as to, they were also an investor in our last round. It's a terrific testimony that I think how they believe that PrevisEA is going to do in the marketplace. And toward the end of this presentation today, Kent Kraft, who is VP of Sales there, is going to provide you with their reasoning as to why they felt compelled to put a significant investment into Entac. I think that'll be very interesting. Today, the format is Dr. Cromwell is going to go through leveraging AI for precision medicine and transforming postoperative care. Then we're taking Q&A on his portion of the presentation, and then I'm going to come in and do some additional slides on the market and PrevisEA and value prop. And then Brian Grulke, who was with us today from Volcano Capital, who was the lead in our last round, is going to say a few words about their reasons they invested, and then we'll go to Kent Kraft as well. So with that, Dr. Cromwell, would you please begin your portion of it?
Thanks, Buddy. Thanks very much. Buddy gave you my academic credentials. I also serve as the CMO and Chief Technology Officer for Entac Medical. Very pleased to be here this afternoon. Let me just kick the slides off here. So we're here to talk about a problem and a novel technology that hopefully solves a big portion of that problem. The problem that we're talking about is a lack of precision in postoperative care, and it's related to postoperative ileus. For those of you who don't know postoperative ileus, it's a profound cessation of the function of the GI tract that occurs usually within 2 to 10 days after major surgery on the abdomen, although it can happen from other operations as well. There have been improvements over the course of the last few decades in terms of improved enhanced recovery after surgery protocols and minimally invasive surgery, but yet postoperative management is still impacted by postoperative ileus. When postoperative ileus occurs, it has an impact on the length of stay of patients after major surgery. It has an impact on readmissions, and those things obviously impact patient satisfaction as well. When we lose value in the system, it affects all the stakeholders, including the patient, the payer, the system. And as a result of the fear of postoperative ileus that's present out there, the length of stay is often longer than necessary due to the risk of postoperative ileus developing, and so patients get held longer in the hospital than they might need to be. And on the other end of the spectrum, if surgeons are aggressive in getting patients out of the hospital, there's often a need for readmission to the hospital, which is a big loss of value from postoperative ileus. I just want to clarify some of the terms we're using today. Postoperative ileus I've described. Gastrointestinal impairment is a term you'll hear me use, and it's really a subset of patients who get postoperative ileus. Postoperative ileus occurs with a spectrum of symptoms. On the left side are kind of the minor impact, are things like patients not passing gas, they're feeling bloated, they're cramping. Those things don't necessarily require any intervention. Patients can be discharged and don't require readmission to the hospital for these minor symptoms. What we're really talking about in gastrointestinal impairment is on the other end, things like the patient can't eat or drink anything. They're vomiting. They require a nasogastric tube to be placed for decompression of the stomach. These have a high operational impact on the postoperative care management of those patients. And so when I say gastrointestinal impairment, I'm talking about these major issues. This slide, you may not be able to see all the details present on here, but this is a study that was published in the last few years looking at what's happened with rates of postoperative ileus over time. And the two highlighted procedures, the two top lines in this graph, are the incidence of postoperative ileus in two major abdominal procedures, cystectomy and colectomy. And what you can see is that using the HCUP-NIS database over a 10-year period, they found increasing rates of postoperative ileus. And again, this is despite the increased use of minimally invasive and robotic surgery and enhanced recovery after surgery protocols. The idea here is just that we have not solved the issue of postoperative ileus. And I'll just have you look, the line for colectomy ends right around 20% or so. And just keep that in mind, because we did a study as part of the clinical trials with our technology, a multi-center study. We looked at the incidence of gastrointestinal impairment in a prospective manner across the sites in the trial, and found just that, a 20% overall rate of gastrointestinal impairment in those populations. Postoperative ileus, as I mentioned, also causes an issue with readmissions. And I don't expect you to be able to see all the small print here, but the yellow highlights are meant to show that over a large cross-section of patients in the United States who have abdominal surgery or even other surgeries, postoperative ileus remains either the number one or number two cause for readmissions. And again, this is because the unpredictability of postoperative ileus. Obviously, surgeons wouldn't send patients home if they knew they were going to develop this issue after discharge. And so it remains to be a problem for readmissions as well as length of stay. It's understood in medicine that we really can't predict postoperative ileus just by looking or listening to the patient. However, we decided to put some data around this to see actually what the performance of surgeons are at predicting which of their patients would develop postoperative ileus. We asked 4 surgeons at the University of Iowa in 82 consecutive colorectal resection patients a question on postoperative day number 1, that's 12 to 16 hours after the surgery had been completed. We asked them to predict whether that patient would ultimately develop gastrointestinal impairment using our definitions that were supplied. And what you can see is the sensitivity and the specificity are rather poor, and the accuracy is somewhere around the flip of a coin in terms of understanding which patients would develop postoperative ileus. And this just lends support to what we already know, that this is that surgeons aren't able to tell at 12 to 16 hours after surgery which patients are going to develop postoperative ileus or gastrointestinal impairment days later. There's another trend that's driving interest in postoperative ileus, and that's the problem of or the opportunity for ambulatory colectomy. This is surgical procedures where an intestinal resection is done and the patient is discharged either the same day or within the first postoperative day. The interest in this has been spurred since the pandemic because of bed crunches and other issues and access to the operating rooms and driving an interest in this, in addition to the significant economic issues associated with long length of stay. This renewed interest requires us to understand what factors are driving patients to be readmitted to the hospital or who will do well after discharge. From feasibility studies, we know that more than 30% of patients are likely candidates for such ambulatory colectomy. However, in the most recent years of the American College of Surgeons National Surgical Quality Improvement Project data, only about 2.5 or so colectomies are being done with a length of stay of less than 1 day. You can see that here. This is just a histogram showing the distribution of colectomy cases across the country in the NISQIP database. That first bar is those that are being discharged within postoperative day number 1. So there is an opportunity for a very big shift for many of these cases to be done as ambulatory surgical cases. However, the problems of not understanding which patients will develop postoperative ileus are magnified in this case because these patients are going home very early. And you can see when we look at what happened to that small swath of patients who had ambulatory colectomies, the major cause of readmission, 52.9% of those readmissions were due to postoperative ileus, followed in a distant second by surgical site infections and then other issues. So the takeaways from this part of the presentation are really that we've not been able to have a big impact, or essentially no impact at all, from trying to improve or reduce postoperative ileus and gastrointestinal impairment. Certainly the cost and the quality of postoperative care would benefit if we knew which patients were going to develop this problem and optimize their postoperative care pathways. And additionally, a precise understanding of these risks will be an important enabler for ambulatory colectomies to expand. So the solution that we're here to talk about is the device known as PrevisEA. This is a device and a technology that I became interested in more than a decade ago as I saw patients suffer from postoperative ileus and be readmitted. And our focus in my lab at the time was to use machine learning and techniques for predicting this problem using a library of intestinal sounds that we had collected on surgical patients. And ultimately, we developed a novel biomarker called MH4 from that data and subsequently validated that to identify the risk of gastrointestinal impairment 2 to 10 days after surgery. This graph on the right shows what we see from MH4 in both patients who do or don't ultimately go on to develop gastrointestinal impairment. The x-axis is the day after surgery, the postoperative day number. The y-axis is the MH4 counts of that biomarker on any given day. And the top curve here is the patients who subsequently did not develop gastrointestinal impairment. And what you'll see is that over their time in the hospital, their MH4 values are much higher than the other segment, which is those patients who did go on to get gastrointestinal impairment. Importantly, what's not shown here is that these two curves actually diverge about 8 to 12 hours after surgery. And so that's the time when we're able to predict which patients will go down which pathway using PrevisEA. This is the device current state. We've embedded the algorithms for detecting MH4 into this device. It's about a 3¼ inch in greatest diameter with an adhesive backing. I won't read through the FDA label here, except to say that the label states that this device is for determining the presence of abnormal digestive health in patients following major abdominal surgery. That statement, major abdominal surgery, is important because that is an expansion. The FDA allowed us to change the language from intestinal surgery to major abdominal surgery, which expands the market for this about 6-fold. The device is quite easy to use. The device is placed on a quadrant of the abdomen using the adhesive backing. It's activated by pressing the power on button. And 12 hours after this is applied, it provides an output of the Previs index, which is either high risk or low risk. And that Previs index is used to guide further postoperative care beginning at that 12-hour time point. The low-risk patients, obviously, what this means is that their digestive health does not support early oral refeeding and early discharge because of the risk of postoperative ileus and gastrointestinal impairment. And alternatively, a high risk means that the digestive health does not support that, and those patients should be essentially slow walked through their recovery. Importantly, these are easily protocolized into a postoperative care pathway that's driven through the postoperative order sets. This graph is really to explain the impact that different care pathways and PrevisEA have on this postoperative pathway. This blue graph, this graph here has hospital day on the x-axis and the incidence of gastrointestinal impairment on the y-axis. So the blue line just represents if a patient's going to develop an ileus, when does that generally happen after surgery? And what you can see is that postoperative day number 3 is about the peak incidence. And there's a long tail of postoperative ileus that develops over the next several days. There's virtually none very early on after surgery, and it develops later. I'll draw the attention to the right red arrow here called conventional discharge. When patients, what we're referring to with conventional discharge is patients who have a rather old-fashioned way of being managed, which is where they wait for the patient to have a bowel movement or start passing flatus and things before they actually feed the patient and discharge them. Those patients end up with a very, very long length of stay, 8 days in the hospital, very unnecessary for most patients, and this results in a big loss of value. More contemporary protocols are those that are called ERAS, or enhanced recovery after surgery, where patients are fed early on, even on postoperative day number 1. And if they appear to be tolerating a diet, they're discharged several days later. This results in a much lower length of stay. However, there's a long tail of patients who will ultimately develop postoperative ileus and require readmission. Again, a loss of value on that end. And then this arrow, ambulatory colectomy, is essentially patients who are candidates for that would be discharged on postoperative day number 1, even before they've had a chance to assess whether they're tolerating a diet or not. Importantly, PrevisEA comes into this very early on at 12 hours after surgery. So we're able to identify the risk of patients developing postoperative ileus and advise the surgeon on which pathways might be appropriate for that patient. This slide is on the performance of the device that we're talking about. We have calibrated the device very specifically to achieve certain clinical outcomes. One of those is the sensitivity of the device. This is the performance value that we want to maximize this to detect all possible patients who will develop postoperative ileus. The sensitivity of nearly 86% is a very, very good sensitivity for a predictive device such as this. The other important value is the negative predictive value. This is the value that says if the device says the patient is at low risk for developing gastrointestinal impairment, that they actually don't develop gastrointestinal impairment. And so this is a 95% performance in that particular metric. And this is important because it drives confidence that the device can tell you which patients may be successfully fed and discharged to home with respect to gastrointestinal impairment. The benefits of this is obviously personalizing postoperative care, identifying those low-risk patients and allowing them to get out of the hospital much earlier, perhaps 3 to 5 days earlier, with or even more than that with ambulatory colectomy. Identifying those high-risk patients and treating them appropriately, not discharging them until they actually have return of bowel function, saving readmissions from the tune of maybe 20% down to under 5% with the device performance numbers. This results in an increase in patient safety and satisfaction and turns these current losses into profits, particularly within a fixed payment DRG system. Before I turn this over to Buddy to talk more about the ROI and healthcare economics here, I do want to say that we are continuing to iterate on development of this technology. We've begun working on the next generation called PrevisAI, specifically called PrevisAI Gut. This is a device that is that is based upon AI and deep learning, and we're targeting a 510(k) submission and probably in 2025. The advantage of this is it has better performance out of the box with the improved algorithms, and so we hope to improve the sensitivity and specificity even more. It's continuously improved because the device is exposed to more and more clinical data. We're able to improve the performance and recalibrate it. And importantly, because this is a cloud-based platform, we're collecting that data continuously. And the cost of goods here is about half of what it is for PrevisEA, which results in improved margins for Entac. We're also looking at the expansion of this platform into other areas, including predictive applications and things like asthma, COPD, and congestive heart failure, which collectively, constitutes more than 40 to 45 million additional patients who could be potentially helped with acoustic applications on this platform. And we're collecting feasibility data. We hope to have that by the end of the year. The graph on the right just shows the layout of this platform. It's all based on the PrevisAI cloud, and there's divergent pathways. One is for hospital inpatients, which is the PrevisAI Gut device, which has a embedded IoT cellular connection for sending data. And then the other heart and lung devices are envisioned to be outpatient devices for monitoring patients who are at home, and these would reach the cloud through a smartphone application as the gateway. With that said, I would be happy to take any questions if you can enter those into the chat, and happy to answer those if anyone has any.
Great, John. Thanks for that presentation. I have a couple of questions that came in already. Can you explain how MH4 predicts postoperative ileus?
MH4 is a subset of the audio that's generated by the gut. So as the gut peristalsis, it through the interface between gas, liquid, and solid in the GI tract, it creates certain patterns of sound. What we believe is going on and why this works well is because we're detecting some very subtle, nuanced changes in the frequency patterns as the bowel goes from being very coordinated peristalsis to the transition zone to uncoordinated peristalsis, which ultimately is what results in the onset of clinical postoperative ileus. So we're detecting that change in peristalsis activity long before it actually presents as clinical symptoms.
Great. Well, it seems as though there's a trade-off between LOS and readmissions depending upon post-op care pathway. How do surgeons, currently choose a protocol? If ARIS has a high readmission rate, then why do they use that protocol?
Yeah, it's a great question. It is exactly that. It is a trade-off. Because, as we demonstrated, surgeons can't predict what's going to happen to these folks, they basically will choose a way that they're comfortable with. The benefits of using an ERAS protocol are that 70% of patients who, the 70% who are not going to develop postoperative ileus will go home, and they won't spend a lot of time in the hospital. They won't be exposed to, risk of hospital-acquired infections and those types of things. And that's at the trade-off of knowing that some patients, perhaps 20 to 30% of those, will need to come back into the hospital through the emergency room. And so that's a comfort level that some surgeons have, or they have pressures on them to reduce their length of stay and choose to use such a protocol. And the other route obviously favors not taking the risk of patients having to come back to the emergency room and accepting the significant economic consequences of having 70% of patients stay an extra 3 to 5 days.
Well, to switch gears for a moment, let's talk about the financial aspect of it. How much does this solution save in the form of patient cost through fewer readmits and just a faster improvement?
That is a great question. And I think I'm going to ask you to hold on to that question for just a second, because Buddy coming up is going to present some data regarding our budget impact model, which addresses exactly that question.
Okay, great. And then you're implementing AI into the solution. What impact is that having on the solution? Is that speeding it up, or is it making it more accurate? Where's the benefit coming in?
Yeah, exactly. That's a great question. So there are several benefits to moving this to AI. Now, when we started working on this PrevisEA more than a decade ago, the infrastructure for doing IoT type technology and executing deep learning models in the cloud simply wasn't there. But we realized that we had this possibility, and so what we've done in the PrevisAI prototypes is we've been able to reduce the number of components in the system, because we don't need to do any major processing of digital signal processing on the device. So the device acts simply as a digital stethoscope, doing some minimal processing of the audio and sending it up to the cloud. There we can use real deep learning to improve the performance of the device. Deep learning offers a number of advantages. It is adaptive to different types of noise conditions that might be present in an environment in a hospital, and those types of things. So we can really begin to improve the specificity of the device with respect to postoperative ileus. And then, as I mentioned, because we're able to reduce a lot of the components on the device, we're able to also reduce the footprint, the physical footprint of the device, and reduce the cost of goods. So that overall improves the margin for the device.
Next question is, how does this impact the physician's work? How much are we changing their current process, and how much training would they need to use it?
Yeah, great question as well. So this is relatively easy to introduce into a postoperative care protocol, because the device, the physician or surgeon doesn't actually need to place the device. The way that it's been used in all the clinical trials up till now, and how we envision it being used commercially, is that it's placed by the nurses in the PACU. The patient comes out of the operating room, the thing gets stuck on the device and activated. It simply sits on the patient for 12 hours, and then postoperative care orders have instructions for different types of cares. It would really simply require that the surgeon add to their postoperative care orders for the nursing staff to record the 12-hour Previs index into the chart. So that's available at the time that they are making, the next day, essentially the next morning, when they're making rounds and making the determination of the next steps in the postoperative care pathway. This introduces them with an additional piece of information that they critically don't have at this moment when they're making those decisions on rounds the next day.
Great. The last question is, where exactly are you on the FDA path, and what's the next milestone with the FDA?
Well, PrevisEA we have that cleared. FDA has cleared it. That clearance was done through a 510K pathway with essentially a digital stethoscope device as the predicate. As I mentioned, we've then subsequently achieved an expanded FDA label to cover all major abdominal surgery. And we expect that the PrevisAI Gut device will go through the 510K pathway as well, with the current PrevisEA device as the predicate.
Great. Thanks. I think that's the questions we have for now. If anybody else has any questions, feel free to go ahead and put them in the chat box. But with that, let me pass it back over to Buddy.
Yeah, just to be clear about that, with the device is actually, we launched the device into the market in the first quarter of this year, and we're going to go over this in a minute. We have many sales reps out there calling on physicians and hospitals, and we'll tell you about the go-to-market strategy in a minute. But PrevisEA is cleared. It's going through the process in many hospitals. The sales cycle in hospitals is relatively long, kind of sales cycle, and we're beginning to get real traction in there, and we'll talk about that in a minute. But it is cleared and on the market, so just want to make that clear. John, you're running the slides. We can move to the next slide, and we've got to talk about the value prop here for a second. So how do we demonstrate to hospitals? And this has been a lot of what we've been doing since we launched the device in the first quarter, is is coming up with the right messaging. There's some nuance here, and there's some, how do we best do this? And what we've come up with is most recently that is really resonating with physicians and hospital executives is we take the data that they report to Medicare, and Medicare assigns them a case mix index. Case mix index is really just how the difficulty of the cases that they get. So it can be anywhere from a 2.5 to a 4.0. And usually, 50% of hospitals have a case mix index between 2.95 and 3.4. Academic medical centers tend to have a higher one than community hospitals because they refer up the chain. And then we determine, we take that, and we find hospitals that are within plus or minus 5% of that hospital's case mix index, and based on that, the number of discharges they do, because we want to compare them to similar hospitals, their peers, and see how they're doing. And in this particular case that you see on the screen here, we divide that at the average length of stay into quartiles, and the higher the quartile are, the longer your length of stay. This particular hospital here is a 4th quartile hospital. So they've got a very long length of stay versus most of their peers. You see there are other 4th quartile hospitals here as well. But then we take that and we say, okay, so based on that, we know that other hospitals, the best hospitals that are doing the best right now are in the 1st quartile. And this particular instance, using PrevisEA could reduce their average length of stay up to 4 days. We could reduce their readmissions about 43%. And we could reduce patient risk of having other downstream events from postoperative ileus like dehydration, acute kidney injury, or aspiration pneumonia, and then have a significant budget impact model. John, if you'll hit the next button there, the budget impact model will come up. And so what this means is this is for intestinal surgery only. This is for DRGs 331, 330, and 329. This is just for intestinal surgery. And in just an intestinal surgery at this particular hospital, when you run it through the model and you take into account all the variables that matter with regard to patient care and bed days saved and those sorts of things, just an intestinal surgery would be almost a $10 million positive budget impact for the hospital. Now, as you broad this out from intestinal surgery into major abdominal surgery, it would probably be 5 times that. So it could be a $50 million budget impact for hospital-wide use in all major abdominal surgeries. And so we can show hospitals very specifically using their own data, so they can't really argue with what we're saying, because this is data that they report to Medicare, and demonstrate to them that we can do this, save them many days in the hospital, readmissions, and positive budget impact. Now you say, well, okay, well, how about the 1st quartile hospitals? Can we help those? Absolutely. Look, the device is $600, basically average selling price. And if you can save 1 day in a hospital, which is the average day in a hospital in the United States is $2,750 per day. So you save them over 4 times even those. Most of those hospitals, you can reduce their at least 1 day, even in the 1st quartile. And those are great hospitals for ambulatory colectomy, which we'll talk about in just a second. Next slide, John. So ambulatory colectomy, this is a 0 to 1 day length of stay. And this is where PrevisEA can really revolutionize postoperative surgery care. I refer to this article just recently in Becker's about how hospital executives are zeroing in on length of stay. The reason is that reducing length of stay is the lowest hanging fruit for a hospital to be able to improve its financial performance. If you can reduce the length of stay, if you took the entire hospital and you could reduce the length of stay by 1 day, you would save tens of millions of dollars for that hospital. So, and as John had said, it is feasible if you can determine which patients are at low risk for postoperative ileus. Right now, when it's done in a very small number of cases, less complex cases. Well, PrevisEA is 95% accurate in identifying patients at low risk for POI. So in this scenario, it makes it very, very crucial to use PrevisEA. A lot of those postoperative ileuses happen somewhere between post-op day 2 and post-op day 5. So if you're leaving your patient in with an average stay of around 5 days, most of those ileus will happen in the hospital. With ambulatory colectomy, it will happen, starting on days 2 to 10. And so all of those patients would develop their ileuses outside, driving a really high readmission rate. So you can reduce the length of stay by 3 to 7 days while keeping the readmissions low in at least 30% of the cases, and we think it can broaden out from there. The cost savings on this is tremendous. It could be as much as $20,000 per case. You have to, and in Medicare in particular, which is generally about 30 to 40% of hospitals' patients, they're losing $11,000 per case. So this can really help them drive better patient care. Getting somebody out of the hospital in a safe way is better patient care. They tend to recuperate better at home and save them money. So Entac is coordinating a collaborative, a quality improvement collaborative. It's based on a collaborative being a quality improvement program being done at the University of Iowa. And it provides a forum for participants to share best practices. We're bringing all these centers together in this collaborative and enables participants to share best practice about patient selection and patient care. It expands PrevisEA as the standard of care in ambulatory colectomy and provides Entac with really a low-cost way to collect length of stay for further sales and marketing efforts. If we hear one thing that a lot of hospitals want, not a lot, but several hospitals wanted, was more length of stay, and demonstrating PrevisEA can actually reduce that. This gives us a low-cost, very efficient way of doing that. We believe this is going to be a huge driver. We haven't even rolled this out yet. We're going to roll out the collaborative in this quarter, but we've already got 6 sites that want to participate in this, and we really believe it's going to expand rapidly from there. So the market for postoperative ileus worldwide is about $6.5 billion or so, we believe. We have IP issued all over the world with this in the EU and China, in the US and other markets. The US market in major abdominal surgery is about $1.5 billion. Similar market in the EU. We believe the rest of the world is about $3.5 billion, although data out of Asia is very difficult to get accurate data, but that's how we come up with the $6.5 billion market for in the postoperative ileus. Our go-to-market strategy, along with CTI, who just made their investment in the company, we have 20 representatives in the field calling on surgeons at more than 400 hospitals, and their call points are colorectal surgeons in academic centers and high volume regional centers. And now, since May, we have the major abdominal claim. There are other places they can call on too, like general surgeons who do a myriad of different major abdominal surgeries, surgical gynecology, and urology. Urology is a big one too, because men who have cystectomies due to bladder cancer have a very, very high rate of gastrointestinal impairment. John, if you could hit that button one more time in there. And so driving growth, we want to expand reps opportunistically across the country from currently about the 20 reps there to about 32 by year end 24. A lot of that came about at the American College of Colon and Rectal Surgeons Conference in June, where we have lots of hospitals across the country who are issuing and use it outside of our current regions, and we will put reps in those areas. And the major abdominal surgery expansion, which increased our market size by 5-fold. The ambulatory colectomy, as I mentioned, we think is going to be huge, and we guarantee the device as well. If the device is wrong, we'll give you another one for free. We won't even charge you for it because of the accuracy. The sites that you see at the bottom here are sites where we have a clinical trial underway there. These sites all want to join it once that clinical trial is over, and we'll be moving into those sites as soon as that happens. John, next slide. Our traction. So CTI has been a great partner of ours. We've been working with them for well over a year to plan the launch of this. And they have 40 years of experience in selling devices in surgery and critical care. They've launched literally scores of devices in these areas. You know, they have established relationships in hospitals in 20 Midwestern states. Their reps have been very helpful to us in honing our message and getting us traction. This year, as of today, we expect at least 6 systems to go through VAC by the end of the year. That could slip or become earlier. You know, it's a very fluid situation. But that represents about 48 hospitals, representing about $30 million in revenue potential as we move forward. Surgeon champions have been identified at additional 38 hospital systems, and we are expected really to be moving in a lot of those in 2024. And then the 6 centers that we already have in the ambulatory collective collaborative who are ready to go on that, and we think that will expand. In many cases, when you're used in a quality improvement program, you can sidestep a value analysis committee. And so once they approve purchase for the collaborative, we will be in there for other uses as well, for inpatient uses. You know, there is nobody who does what we do, and there's nobody on the horizon that we know of who does what we do. Our biggest thing is education process, because this is such a new technology. It's very novel. We have to educate surgeons on the process and the clinical benefits, administrators on the value prop with regard to finances. That's what we're going through right now and honing that message to make sure they understand that value prop. barriers to entry. The low cost of PrevisAI Gut coming up in 2025 is going to make competition very unlikely. We have probably the largest database of vowel sounds in the world, and that's a huge entry to be able to develop product. We have a growing IP estate. We have 3 patents issued in the U.S. and we have others issued in the EU, China, India, and other patents. And we have another patent pending. And then we have the basic applications filed for the PrevisAI Acoustics IoT platform. So where are we? Our capital needs. I just told you that we completed the 1.5 million with CTI's investment in the company. We really appreciate their confidence in what we're doing. They obviously see a lot of potential here because their risk is Salesforce in selling this product when they could be selling other things. The things in blue that you see there here at the bottom of the screen are the milestones that we have coming up, getting through VAC committee and getting hospitals signed up and revenue, feasibility of the data that PrevisAI Heart and Lung that John talked about, and then the national rollout of the colectomy for the rest of the year. And the next year is a very busy year for us. More, the expansion of PrevisEA into more accounts, completing a multi-site trial for the AI Gut product, actually, a prototype in the heart and lung area, and a submission for PrevisAI Gut probably in the first half of 2025, and probably a clearance. We got PrevisEA cleared in 85 days, and PrevisEA will be the predicate device for PrevisAI Gut, so that should go well. We have skipped Europe with PrevisEA really to hone the message and get it prepared in favor of doing PrevisAI Gut, and we'll be doing a CE mark filing in there in 2025, and then we're actively talking to potential partners in Europe and Asia to market the product there. We have a very well-rounded management team. I've got 25 years of experience doing this. I've founded 3 different companies having to do with predictive analytics and AI technology. You know who John is. Andrew Forsdick is our CFO. He's worked with early stage companies in the CFO position for over 20 years. Gene Stefanetta has had 10 years experience in operations, which has been great for us now for manufacturing reasons and being able to audit those functions. Our board members, Terry Wall, he sold his company of over $1 billion to GE Healthcare. And then Sean Fordick, who has 6 exits, large to others. They have helped us with Salesforce crafting and other types of strategy that have been really, really helpful to us. Kent, as I mentioned to you, he's the VP of Sales. He's been there for 40 years doing this kind of thing. And Scott Nelson has helped us on the 1099 rep side outside of the CTI territories. So we've got a well-rounded management team that meets all the challenges that are needed to do a successful launch of the device. So in summary, the AI platform really has the ability to spin several products of it, and the 12-month revenue trajectory due to PrevisEA with significant milestones about drive evaluation increase. PrevisEA and PrevisAI Gut, they do everything that's really hot to hospital executives and surgeons now. Surgeons are really feeling pressure to reduce length of stay while keeping readmissions low. In every hospital we've ever looked at, it has millions of dollars of positive budget impact. With Gut providing an increasing value prop over time, and then significant traction already moving into the last part of the year with the rollout of the colectomy. And the upside really for the company is in rapid development of heart and lung. That's a longer term play. We don't actually believe we will own this company when that happens. What we're trying to do with that technology, the strategy there is to get that technology far enough along in order to demonstrate proof of concept, develop a device, and maybe even partner that program in the interim to move it along faster. So right now, as I said, the note that we have out was the $1.5 million note that we got all that money. The board of Entac decided to leave it open since we have other investors. CTI had done more of an investment than we had anticipated. And so we were in active discussions with other investors that wanted to give those people an opportunity to get into Entac, as well as give the company a little bit more runway with regard to achieving these milestones. And so it's been decided that we will leave the round open until October 31st and take up to an additional $250,000 in investment. So that's the story. What I would like to do now is we have a couple of investors on the line who want to explain to them why is it that they chose to invest in Entac and what they see. The first one is Brian Goulke. Brian is a partner with Volcano Capital. They were the lead in our last round of financing, and they also invested in this round of financing. And they have been a very great partner of ours, brought us lots of contacts and lots of relationships that have been very beneficial to us. And after him, then Kent Kraft from CTI, who made the most recent investment, who's the sales arm of basically Entac, will give you an indication of why they feel like the Entac investment is a good one. Brian.
Well, thank you, Buddy. As Buddy mentioned, I'm a partner at Volcano Capital, and I think it'd be helpful to give just a little bit of background on Volcano, just so people have some context. So Volcano Capital is a family office started by the Wall family. And so Terry Wall is on the board of Entac, was the founder and CEO of a company called Vital Signs, which was a medical device startup itself. And he grew it up over the years and ran it for something like 30 years before selling it to GE in 2008 for a little bit over $1 billion in cash. So it had gone public in the meantime, so that wasn't all Volcano, but it wasn't all the Wall family, but obviously you have a fair amount under management. And I think it's important to note that since they have such operational expertise, strong network and background in the medical device space, they really can bring a lot of value to the table in a way that, say, they're from real estate or oil and gas or something, maybe it wouldn't be as value added. Let's see. So I've been with Volcano for 13 years now, and kind of lead up the direct investments in early stage medical device VC, arm of the family office. And when we look at investments, like we always start with the clinical economic value proposition, and we think that's one of the areas where Entac really stood out to us when we were evaluating it back in 2020. And I think, just to kind of summarize what Dr. Cromwell and Buddy have said so far, I think, postoperative ileus is a real problem that generates real costs to hospitals and drives readmission rates that are very costly to both the patients and the hospitals and insurers. And it's something that you can't predict. And what's interesting about this is that at hour 12 post-op, you're predicting what's going to happen days 2 to 5, even as late as 8 days after surgery, whether or not that patient's going to have a problem. And, one of the slides that Dr. Cromwell showed indicated that, with the internal data, physicians can't predict that on their own, right? It's as good as a coin flip. And so if you plug it in the model and everything, I think the clinical economic value proposition here for Entac is really strong and something that's really attractive to us. And I think the other thing that's really attractive is that it's a 510K regulatory pathway. So but it's still a differentiated product, right? And so I think it's great to have something that's not too onerous of a regulatory pathway. And it's not a PMA pathway or something that's, super onerous and takes lots and lots of time and money. It's something that you can tackle with relatively limited funds. But this isn't a Me-Too product, right? It's the only one out there. And so you kind of have that sweet spot of a differentiated product, plus a relatively mild regulatory pathway. And so I think, and then the final element that I think really drew us to make the investment initially is the strong management team. Obviously Buddy and Dr. Cromwell was a technical founder, and a GI surgeon, colorectal surgeon himself, which I think lends a lot of credibility to the company. So we led the Series B back in February 2020, and since that time, Entac's done a great job executing. Right, they developed the product. They got through the FDA initially with a major intestinal surgery claim that they expanded to major abdominal surgery, so looping in other potential surgeries like cystectomy and hysterectomy and other things that have pretty high POI rates. And so we've been really pleased with how the company's performed. And as Buddy mentioned, we put a fair amount in this note alongside CTI. So I guess just kind of, if I were to put myself in your shoes, if I was a member of the 10 Capital network here, I think I'd be pretty excited about putting some money into Entac personally. I think there's, it's very reasonable valuation and terms for the investment. And there's a lot of very near term real value inflection points that I think that are on the horizon here that could really drive an uptick in value for the people who invest now or the coming months. Those would be things like getting initial sales traction, which I think we're well on our way to demonstrating. And I think CTI is doing a great job driving that. We're also doing a post-marketing trial, which is generating data to really demonstrate the accuracy of the device. And that data is also going to have recordings that will allow John to develop the machine learning derived the AI algorithm, which is hopefully going to be even more accurate than the current one. But even if it's not, the AI version, all the calculations done in the cloud, would be a huge win for the company with lower COGS. So I think that's a win either way. Although I obviously expect it to, the AI version to be even better. And I think as Buddy and John kind of mentioned, there's kind of an out of the money option, if you will, on applying this technology to other applications where you have auditory biomarkers that could be predictive of other disease states. So I think it's a pretty compelling opportunity in my view, and I hope you guys feel the same. Happy to answer any other questions that you guys have, or pass it on to Kent to share his thoughts.
Thank you, Brian. Kent is Kent Kraft. He is the VP of Sales at CTI. And Kent, you just wrote a check. Why'd you write the check?
Thanks, Buddy. Good afternoon. Both Buddy and Brian have stolen most of my thunder. So just as a quick overview, my company is Clinical Technology. We are a contract sales force and specialty distributor in the Midwest. Our area of expertise is bringing new technologies to the acute hospital marketplace, changing protocols and procedures, driving adoption, and then hopefully working towards standard of care. So when we first saw the PrevisEA, the value proposition was interesting to us because it was different. Preventative medicine is very well known outside the hospital, but once you get inside the hospital, once a patient is in the hospital, it's very reactive. You're there to be treated for a condition or a disease, and they react based on how the patient presents. This is different. This is proactive. This is patient-specific treatment based on the patient's predictable possibility of having a post-op ileus at some point during their post-op care. So we saw the value early on, a little over a year ago, and did invest both as a company and with personal dollars about a year ago. It's taken a good year for us to fully understand the value proposition and the stakeholders in the facilities, because it's not just the colorectal surgeon and his team. There's a huge, as Buddy ran through in his presentation, financial impact for facilities. When we take a look at a technology to bring on board for our sales reps, it has to provide improved outcomes for the patient so that there's a patient benefit. And hospital systems now are demanding that it provide a financial component for the facilities. And this provides both in a material and now easily presentable way with the budget impact models. We are starting to see wonderful traction throughout our geography with virtually every one of my sales reps. So it became clear to us that we wanted to be a bigger part of this partnership. So that's why this week, we made the decision to further invest in the company and feel that that PrevisEA is on the precipice of becoming a very real impact product line for my organization. And we're also extremely excited about the prospects of how this technology can be utilized for other applications. Interesting, the reactive to proactive seems to really be a thing because over just the last month, we've been approached by other technologies for other areas in the acute space that have the same general messaging of personalized medicine and being proactive rather than reactive. We really think that that's a thing, and that the PrevisEA is at the forefront. So we're joined at the hip with these guys, and it's my personal quest to make sure that it's a huge success. Thanks, buddy.
Thank you very much. I appreciate that. These guys are not just investors. They don't just write checks. I mean, they're integral parts of our team, and they really expand our bandwidth as a company. That reactive, proactive language that Kent was just using actually came up in a phone call Kent and I were having a couple months ago, just sort of strategizing about sales. And Kent used those two things, and I'm like, we've got to use that. And we put this in some of our sales materials that we call a 2-pager, and it really has been. It really sort of really coalesces what when you go in and talk to the physician that, yes, right now, doctor, you're being reactive to everything, and this can enable you to be proactive and make proactive decisions with regard to that. So it's been these guys, both of these organizations we are proud to be associated with them, and they have really expanded our width. They bring us depth and experience in every place that we need to be. Well, if you're interested in that round, it is going to close on October the 31st. We have $250,000 left, basically, of capacity in the extension, and it will be closed. Hall, I think that's all that we have. We appreciate everybody's time for showing up today and your interest in Entac. We're happy to follow up with any of you individually to ask any questions. Please just let us know what you need. Thank you very much.
Great. Thanks, buddy. Thanks, John, Brian, Kent. Great presentation today on the Entac Medical Update. Those in the audience, we encourage you to fill out the poll, and be glad to follow up with anybody with interest and provide information as well. With that, we'll go ahead and close it for today, and we'll look for seeing you guys next time. Have a good one.
Thank you all. Appreciate it. Bye-bye.
Bye-bye.